CBMT domains. So there are 5 domains: safety, referral, assessment, interpretation of assessment and treatment planning, treatment implementation and documentation, evaluation and termination of treatment, and professional development and responsibilities, all with their corresponding items. For safety, we have 10 items. First, recognize and respond to situations in which there are clear and present dangers, not just to the client but as well as to others. The next is recognize the potential harm of music experiences, the potential harm of verbal and physical interventions. That's why we use them with care. Observe infection control protocols, and then recognize their health conditions so that we also know which experiences are contraindicated for them, and then comply with safety protocols, of course, especially when transporting, and also to provide physical support of clients. Then inspect materials and instruments on a regular basis. Next is maintain awareness of their location, the materials used, and the potential risk of harm at all times. Then also comply with emergency procedures and utilize consistent interactions to promote a sense of safety and security. So these are just some side notes. Universal precautions: basically all blood and body fluids of all patients are considered potentially infectious for HIV, HBV, and other bloodborne pathogens. So that's why we use protective barriers such as gloves and all that. For the scope of practice by AMTA, so first, ensure public protection, and then second is requisite training and skills. So we should provide within the scope of practice that reflects the level of competence, and with that you should also develop a continuing scale of sets. Then EBP, meaning evidence-based practice, so we should also integrate the best available research evidence. When there's an overlap in services, always recognize it and acknowledge. And then you can also do professional collaboration through referrals. And then, of course, always provide client-centered care by being respectful and responsive. For standards of practice, accept referrals, collaborate to review your patient's diagnosis, the treatment plan need, and then treatment plan. Then, of course, do an assessment if eligible, and then develop the individualized music therapy treatment plan, implement it and adapt it accordingly. Evaluate, of course, the responses to music and to the treatment plan, and of course document it, and then terminate when appropriate, and also include a follow-up plan for determination. Then try to minimize the barriers and utilize the knowledge and skills to determine appropriate actions. Now let's move on to the second domain: referral, assessment, interpretation of assessment, and treatment planning. So first, let's learn about referral. Of course, you should implement an appropriate referral system for the population served so that the people will know what to do, and then educate them, of course, the referral criteria, the things that they need to do in order for them to refer it to you, based on the population needs, of course, and then evaluate the appropriateness of a referral, and then prioritize it according to the immediate client needs. So basically for this subdomain, we have 4 things to remember: referral system, educate referral criteria, evaluate it, and that responsibility belongs to MT. And when you accept referrals, you should base it on the client need, the therapist's expertise, and their current caseload. And lastly, prioritize. Prioritize based on their immediate needs. So when doing your assessment, you should always observe your client both in music and non-music settings for comparison. Obtain as well their information from available resources, and then using music therapy assessment, try to identify their functioning level and strengths within the areas of need, such as cognitive, communicative, musical, physical or motor, psychological, sensory, social, as well as spiritual. Identify also their active symptoms if they have, behaviors, clinical history, everything. Then family dynamics and support systems, their learning styles, their mood or affect, multicultural and spiritual context, music background, skills, and then their need for assistive technology, resources, social and interpersonal relationships, stressors they have related to the present status, including trauma, and as well as their values, preferences, and interests. Next is, of course, we should always document assessment information and then understand the possible side effects of drugs. Then select musical and non-musical assessment tools and procedures to reflect the purpose of the assessment. Then, of course, we need to determine the purpose of the assessment. Why we're doing it. Is it only for like eligibility, or maybe identify their level of functioning and all that? Then, of course, we need to adapt existing assessment tools and procedures. We can also develop one, and then create an assessment environment or space conducive. Then engage the client in musical and non-musical experiences to obtain assessment data. We also need to know their response to different elements of music, the style, the types of musical experiences, if it's improvising, recreating, composing, and the types of non-musical experiences for comparison. Basically, for assessment, always know how to assess in a variety of conditions, including how to assess in each domain. Know the active symptoms and behaviors as well as the side effects of drugs taken, and always compare non-musical and musical responses, and then include the functional level, their strengths, interests, preferences, and values, and of course, the environmental considerations. In interpreting the assessment information and how to communicate results, always consider that there's always going to be a presence of bias in information from any source, and identify the external factors that may impact the accuracy of the information gathered during the assessment, of course. Then draw conclusions for recommendations based on the analysis and interpretation of the assessment findings. Now, for the last two, always acknowledge the therapist's bias and limitations in interpreting assessment information, and when you communicate these findings and recommendations, you should communicate it in an understandable and useful manner in any form. To summarize this subdomain, always consider and acknowledge that there's going to be bias, identify the external factors and limitations, communicate it in an understandable manner in any form, and draw conclusions for recommendation only based on assessment findings. For treatment planning, involve the client in the treatment planning process when appropriate. 2. Consider these things: the expertise of the therapist, if they are using research evidence, interventions, the values, preferences, and interests also of the families, the clients, and the caregivers. Then another one is collaborate with other professionals in designing interdisciplinary treatment programs. Next, always evaluate the role of music therapy in that program. Consider the frequency, intensity, duration, and service delivery model, whether if it's for group or individual. And then when you establish your goals and objectives, it should always be SMART. So SMART: specific, measurable, achievable, realistic, and time limited. Again, SMART. Then determine the data collection system that is appropriate for your treatment goals and objectives. Then create an environment good for client engagement. Consider the age, culture, language, music background, and preferences. And when you design these experiences, try to generalize it based on their goals and objectives across the different things. Then select appropriate musical elements, repertoire, instruments, and equipment consistent with treatment needs. Then select non-music materials that is consistent with your goals and client's learning styles. Structure and organize these experiences within each session to create therapeutic contour. Then create and document the treatment plan, and of course determine what are the exit criteria. As a summary, when treatment planning, the goals and objectives should always be SMART. Try to modify and adapt it. and then involve client when appropriate and try to collaborate for interdisciplinary treatment programs, and with that try to understand the role of MT. Then always provide a proper environmental setup, consider everything that is necessary, provide structure and evidence-based intervention, and determine the exit criteria. Now for the third domain, treatment implementation and documentation. So first, implementation. We can develop therapeutic relationship by being fully present, authentic, and respectful to the clients and to the families, building trust and rapport, establishing the boundaries and your roles and expectations, and always provide ongoing acknowledgement of the progress and reflection, as well as a safe, contained environment, recognizing and managing aspects of one's own professional and personal biases, feelings, and behaviors that affect the therapeutic process, for example, transference and countertransference, and then lastly, understanding group dynamics and processes. Next, try to provide individualized music therapy experiences to address clients' ability to empathize, to use music independently for self-care, for abuse and trauma, for ADLs, adjustments to life changes or temporary or permanent changes in ability, aesthetic sensitivity, affect, emotions and moods, agitation and aggression, anticipatory grief, anxiety, attention, auditory perception, autonomy, bereavement, and coping skills, by being danger to self or others, if they have self-injurious behavior, depression, family dynamics, enunciation and vocal production, the executive function and functional independence, generalization of skills, grief and loss, group cohesion, impulse control, initiation, interactive response, and language skills, memory and motor skills, and musical and other creative responses, neurological and cognitive function, on-task behavior and oral motor control, for pain, participation or engagement, physiological symptoms, quality of life, range of motion, reality orientation, relaxation, respiratory function, responsibility for self, self-awareness and insight, self-esteem, self-motivation and sense of self with others, sensory motor skills, sensory orientation, sensory perception, sensory processing. The social skills and interactions include spirituality, strength and endurance, stress management, support systems, verbal and nonverbal communication, as well as wellness. Next, know the theoretical frameworks: behavioral, biopsychosocial, cognitive, holistic, humanistic, or existential, neuroscience, and psychodynamic, and of course utilize the music therapy approaches: the behavioral, community music therapy, culture-centered, developmental, health and wellness, humanistic, improvisational, medical, neurological, and psychodynamic. For us to achieve therapeutic goals, musically speaking, try to apply a variety of scales, modes, harmonic progressions, standard and alternate tunings, elements of music. You can arrange, transpose, or adapt music, or you can also compose vocal, instrumental, and digital music, employ functional skills with digital instruments, guitar, keyboard, percussion instruments, ukulele, and voice. Try to improvise using instruments, voice, or movement. Try to sight read music. Try to utilize varied music repertoire. Then music and movement, music to communicate with the client, song and lyric analysis, songwriting. Try to mediate interpersonal problems within the session. Provide musical cues. Utilize leadership or group management skills, prompting hierarchy, verbal, gestural, model, visual, physical, auditory, or tactile. Then, of course, employ active listening, mindfulness techniques with music, using music relaxation or stress reduction techniques, facilitate community building activities, generalization, then identify and respond to significant events, integrate current technology and interactive media, observe their responses, then try to offer coaching to family, caregivers, and peers to maintain support and clients' therapeutic progress. Then provide receptive music experiences, share musical experience and expression with clients, utilize materials, equipment, and assistive technology, utilize breathwork, creativity, and flexibility, imagery, relaxation techniques, and validate client's musical experience. For the last subdomain for documentation, monitor their progress using a selected data collection system. Always record their responses, progress, and outcomes. Then try to use terminology appropriate for the population and setting. Then document plan for subsequent session. Then try to provide periodic treatment reports. And of course, adhere to internal and external legal, regulatory, and reimbursement requirements. Lastly, provide written documentation that demonstrates evidence-based outcomes related to addressed goals or interventions. As a summary, when developing therapeutic relationship, you can develop it through trust, rapport, boundaries, expectations, and knowing when there is transference and countertransference. Know theoretical orientations and approaches more than their definition. What are the hallmarks of the treatment process in any given model or approach? And then know how to set and adapt goals and objectives and track data based on that approach. Then apply music theory in clinical settings and CPT codes, current procedural terminology codes. So these are medical code set, created, and maintained by the American Medical Association, used by the physicians, allied health professionals, and all that to represent the services and procedures they perform, and for documentation, use SOAP, Subjective Objective Assessment and Plan. As mentioned earlier, reimbursement process. So basically, there's a third party that pays or insures health or medical expenses on behalf of the beneficiary or recipients. Could be like commercial insurance, Medicare, or Medicaid. A requirement for that is like there should be diagnostic codes, the billing sheets, and proof of the MTBC credential of the music therapist. For documentation, use first-person language and use terminology appropriately, and also be respectful. For type of recordings, you can do continuous, event, fixed ratio, interval, and then always provide written documentation of responses, progress, as well as outcomes. For the fourth domain, evaluation and termination of treatment. So first, with evaluation, try to review data and information relevant to the process. Then always differentiate between empirical information and the therapist's interpretation. Acknowledge the therapist's bias and limitations in interpreting information. We are not perfect. Then try to review treatment plan regularly, modify it as needed, and then analyze all available data to determine effectiveness of therapy. Communicate, of course, with the client and the family, caregivers, treatment team, and personal network as appropriate. Make recommendations and referrals as indicated. Compare the client's and therapist's subjective experience or response to music, and then document music therapy termination and follow-up plans. For termination of treatment, always provide data-based or reasoning for termination, then involve and prepare the client and others for the process, and then use variety of plans, strategies in coordination with the treatment team, assess potential benefits and risk of termination, and then of course provide client with transitional support and recommendations, and try to help client work through feelings about termination, and try to address client needs during staffing changes. As a summary, when you set objectives and expectations, it should be within typical length of treatment for a specific type of condition. And then when there's a discharge or discontinuation, the MT writes an evaluation of the entire music therapy process, from the initial goals to the progress made and the functional level at the time of termination, and of course including recommendations. And then provide reasons for terminations, whether its goals achieved, fails to benefit, or can no longer be scheduled or discharged. For the last domain, professional development and responsibilities. So first, professional development. Try to assess areas for professional growth, prioritize and establish plan of action. Try to integrate current research and literature in your practice, participate in continuing education, doing collaborative work, utilize also supervision and mentoring as needed, expand musicianship, leadership skills, and therapeutic effectiveness, and then lastly, develop and advance technology and interactive media skills. For professional responsibilities, first, always adhere to the CBMT Code of Professional Practice. Conduct oneself in an authentic, ethical, accountable, and culturally sensitive manner that respects privacy, dignity, and human rights in all settings. Maintain knowledge of federal and state laws, rules, and regulation that may affect practice. Work within facilities' organizational structure, policies, standards, and emergency procedures. Practice within the scope of education, training, and abilities, and fulfill legal responsibilities associated with a professional, and then access patient information on a need to know basis or the level deemed necessary to appropriately facilitate services. Maintain client confidentiality as required by law, the HIPAA and IDEA. Maintain professional and effective working relationships, professional boundaries as well, and ethical music therapy practice. Examine one's own assumptions, values, and biases. Monitor also your own mental and physical health and seek support as needed. Then prepare accountability for documentation for facility administration or to anyone. Communicate with colleagues regarding professional issues and document relevant communications. Conduct information sharing sessions, then respond to public inquiries about music therapy, be an advocate for the profession, then engage in business management tasks, maintain the equipment and supplies, and then supervise staff, volunteers, practicum students, or interns. So some side notes: HIPAA, or Health Insurance Portability and Accountability Act. So it is a privacy act where we cannot share information, but there's what we call as de-identifying, meaning it neither identifies nor provides a reasonable basis to identify an individual. So there's a removal of client information such as street address, SSS number, email address, and then we can share information but within medical contexts only. So there's PHI, protected health information, so it protects all individual identifiable health information in any form. Refer to another music therapist if the client needs are not within your training and abilities. That's why we should stay within the scope of practice at all times. For AMTA Code of Ethics, so we have 5 principles. First, respect dignity and rights of all, act with compassion, be accountable, demonstrate integrity and veracity, so we should always be accurate and truthful, and then strive for excellence. And then for the CBMT Code of Professional Practice, so these are just some parts of it. So CBMT, Certification Board for Music Therapists, so it's a non-profit org. So there, no individual is eligible to apply for a maintained certification unless in compliance with all the CBMT standards, policies, and procedures. Then usually the individual shall notify CBMT within 60 days of occurrence of any change in the name, address, telephone number, and any other facts bearing on eligibility or certification. And then there's also like subsections about the property of CBMT, the application and certification standards, the establishment of special disciplinary review and disciplinary hearing, sanctions, period of ineligibility following revocation, continuing jurisdiction. So that's it. Thank you for listening.